Welcome everyone to the December 22nd, 2020 COVID-19 clinical rounds on critical care, pediatric ICU care of adults. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Streminger and his team for the peer-to-peer learning platform we use for these rounds. Today's clinical rounds are the last for the calendar year 2020. COVID-19 clinical rounds for 2021 will begin on Monday, January 4th with EMS rounds. Those rounds on Monday, January 4th will be an EMS medical director perspectives session with Dr. David Tan, the president of the National Association of EMS Physicians, presenting. On Tuesday, January 5th, will be an update on critical care challenges and successes. Dr. Oren Friedman, Associate Director for Cardiac Surgery ICU at Cedars-Sinai Medical Center, will be presenting. And as he indicated in an email to me, he's very busy. On Thursday, January 7th, will be emergency department rounds, an update on emergency physicians with Dr. Sandy Schneider, who is a frequent panelist on these rounds, representing the American College of Emergency Physicians. Also want to give you a heads up on a new series that we began, I think a week or two ago, on outpatient therapeutics. And that is focused right now on monoclonal antibodies, and would very much encourage you to look for those announcements and register for those rounds. If you're unable to attend, they're all recorded, as you well know. I'm now going to pass this over to Amanda for some announcements and logistics. Thank you.
Thanks. Hi, my name is Amanda Dzan with Project ECHO. I have just a few quick things to go over before we get started. On your Zoom screen, you'll see a Q&A function at the bottom. Please use that for any questions or comments you have regarding the presentations. There's also a chat. Please use that for any questions regarding technical or logistical issues, and we'll also be using the chat for the crowdsourcing question that'll come up in just a minute. This session today is being recorded, and your attendance is consent to be recorded, so thank you. The presentations that'll be shared today are linked to the most recent email announcement from us at Project ECHO that went out this morning, and it will also be available on our website along with a link to the recording. In about the last 15 minutes, we'll put a link in the chat for an evaluation to claim your CME or continuing professional development credits. They're through the University of New Mexico, where Project ECHO is located. And the link is also available in that same email announcement that went out this morning. One last quick reminder to everybody that these sessions are focused on improving patient care and health systems and supporting clinicians. So we appreciate everybody keeping things apolitical and non-commercial. A quick note on data use. We do collect data through various forms of registration, participation, chat, Q&A, and all of that. However, we want to just make sure everybody knows that everything is de-identified before we share it with HHS, and your personal individual data is kept confidential. As Dr. Hunt said, the NETEC has a webinar series that are complementary to ours. You can go to their website and find I think right now they don't have any new ones scheduled, probably for the holiday season, but you can find recordings of their most recent ones. And we do have that outpatient therapeutics mini series. The next session will be Wednesday, January 6th. And we'll put a link in the chat where you can register or see resources from past sessions. The AAMC also has a continually updated COVID-19 clinical guidance repository. We can also put a link in the chat for that, or you can see the link right at the top of the screen where you can check out that. And back to you, Dr. Hunt, for the crowdsourcing question.
You'd think I'd know about that mute button. Bruce wasn't here to like, yeah. Anyway, it seemed like a good time to be looking forward to something. So this, my crowdsourcing questions tend to be just like one single answer, but this two-parter. What are you most looking forward to over the holiday in 2021? Since we started in March 24th, this indeed has become, how to help take care of patients in clinical operations, but also a self-help group. And we've learned from each other. So highly encourage you to participate in the crowdsource question. So the other comment I want to make before I have our panelists introduce ourselves, and if the panelists can take themselves off mute, we'll just go around quickly. But Amanda said something that I actually is remarkable to me, and every time I hear it, it's in the beginning announcements and so forth, so on, encouraging people to stay apolitical. Since we began rounds on March 24th, given what we've all been through this past year, our experience with the rounds, now I think this might be 102, something like that. 102, 103. There's been one political comment in the chat, one, which to me is a remarkable testimony to the clinicians who participated in their focus on patients, and just want to thank people for that. It's not small. So let me go to our panelists, and I'm going to start with Harry, if you could quickly introduce yourself, and then we'll move to Carol and then Mike.
Sure. My name is Harry Seibold. I'm an EM and EMS physician from Helena, Montana. I'm the past state EMS medical director for Montana and currently on a COVID assignment in Odessa, Texas.
Thanks, Harry. Dr. Cunningham.
Good morning. I'm Carol Cunningham. I am an emergency physician, and I am the state medical director for the Ohio Department of Public Safety Division EMS.
Yeah, thanks, Carol. Mike.
Good day, everyone. My name is Mike Anderson. I'm a pediatric critical care physician and healthcare administrator. I'm currently on sabbatical, working full-time for HHS ASPR on the pandemic. And I just want to thank Rick for putting on this important topic today.
Yeah, and thanks to Dr. Anderson for helping me identify speakers. It's, I couldn't have done it without you, seriously. So with that, I'm going to introduce our first speaker and really appreciate her joining us today. This topic is of particular interest given where we are in the pandemic, and appreciate her accepting the invitation. Dr. Phoebe Yeager is chief of the Division of Pediatric Critical Care Medicine at Massachusetts General Hospital. Phoebe, welcome, and I'm going to turn it over to you.
Super. I'm going to share my screen. Great. Can everybody see that? So hello, everyone, and thank you for inviting me to participate in this wonderful webinar series through Project ECHO. It's truly an honor to be here. I'd like to spend the next 10 minutes sharing both the successes and the challenges our PICU experienced when we repurposed our unit for adults this past spring, with the hope that this might be of some help to those of you who have been or may be asked by your hospital leadership to do the same. So let me begin by providing some context. MGH is a 99-bed university-affiliated general care hospital located in Boston, Massachusetts. And it serves as both a community hospital for some of the most hardest hit neighborhoods in the region during this pandemic, but it also serves as a subspecialty care referral center. We have 9 ICUs in the hospital, 2 what we refer to as legacy medical ICUs, and 7 other subspecialty ICUs. MGHFC, or Mass General Hospital for Children, is a pediatric hospital within the general hospital. And our pediatric ICU is a 14-bed med-surg unit. We have approximately 1,100 admissions per year. And importantly, we are one of 4 PICUs in Boston, which I know is a rarity in most other cities. So Massachusetts quickly followed New York in becoming an epicenter of the COVID-19 pandemic last spring, and MGH activated its hospital incident command system in March. Based on concerns that we would run out of ventilators and knowing that there was plenty of capacity in the other PICUs across the city, it was announced that no ventilators would be used for pediatric patients. And this essentially meant regionalizing pediatric critical care and, practically speaking, shutting down our entire pediatric inpatient service. This all happened very quickly, and within days, our unit filled with adults with COVID ARDS. So faced with the dual challenges of transitioning from treating children to treating adults and implementing dynamic COVID-19 care recommendations, we strongly advocated to preserve the PICU nurse physician team rather than risk being redeployed and separated to other units. So we felt like this allowed us to capitalize on years of established relationships within a familiar environment and ensured a rapid transition. It also really boosted morale. We decided it would be best for the PICU attending to be the primary attending for the adults, but we recognized that there were gaps in knowledge and skills related to providing adult critical care. Therefore, we expanded our team to include medicine and med-peds residents, and we obtained a MICU consult on every patient. This attending came to the unit twice a day to review care plans and was available at all times to field questions. When subspecialty consults were needed, we consulted our adult colleagues. The only exception was nephrology, where our pediatric nephrologists, they ended up helping their adult colleagues due to the high volume of patients across the hospital requiring CVVH. So in order to extend the expertise of our ICU nurses, we created nurse dyads made up of an ICU nurse and a floor nurse to care for 2 patients. So one of the most important questions I think we asked ourselves straight off was, what does the team need to feel safe? The team was initially quite scared about catching the virus, scared about passing the virus on to their loved ones, scared about our ability to competently take care of these adults, and scared that many of them were going to die. Having nurse physician leadership physically present on the unit every day seemed very important. And I think that it really promoted bidirectional communication and sent the message that we cared and we were in this together. Our routine morning nurses huddles organically morphed into a full team huddle where we shared important updates, practiced together donning and doffing PPE, and explored how to optimize workflows that weren't running smoothly. During these inpatient huddles and in daily email updates to the team, we passed along the rapid fire updates being shared with leadership from HICS, and we tried to be completely transparent about what we knew and what we didn't know. I've already touched upon some of the considerations regarding staffing. I'll talk more about that later. While there was a threat to not having enough N95 masks, I will say that our hospital was extremely lucky that we never ran out of PPE and our team always had what they needed to safely care for our COVID adults. And lastly, the team expressed a lot of worry around medical legal protection when providing care outside our scope of practice. And hospital leadership was very responsive at extending emergency privileges, and we received reassurance from our malpractice insurance company that these privileges would be covered. The next question that we asked was, what does the team need to provide safe care? The learning curve to care for critically ill adults was very steep, and we focused a lot of attention on education delivered in a number of different ways. Our nurses floated to the adult ICUs to get a sense for their pump setups and other nursing workflows. And the Department of Medicine developed a robust web-based platform where they posted clinical care resources and recorded talks on all variety of COVID-related topics. In addition, our adult colleagues developed a hospital-wide pocket treatment guide for care of the critically ill patient with COVID-19. We also, in addition to relying heavily on our MICU consultants and medicine residents and med-peds residents, there were other adult experts who really came forward, including our adult pharmacists and adult ICU nurses. A 24/7 warm line was set up for nurses, where our nurses could reach out to adult ICU nurses to help troubleshoot various issues, and they were very good about actually coming down to the unit when needed. In addition to the pocket guide for care of the critically ill COVID patient, we also provided the team with ACLS cards, and we did an internal crash course in ACLS. We also provided adult medicine dosing cards. Within a couple of weeks of the first surge, there was centralized intubation, vascular access, and proning teams that came online, and those helped tremendously. Careful patient selection was paramount, and I'm going to address this more in a minute. Lastly, in order to focus our attention on the patients, the clinical support services responded very quickly to ensure we had everything we needed to take care of our adult patients. So obviously the pivot to adult care and worries about personal safety and safety of everyone's families took a significant toll on the team. And we tried to be really deliberate in the ways that we promoted well-being. In addition to the team huddle I mentioned earlier, we had wonderful pediatric psychiatrists and members of our palliative care team who came by the unit for informal check-ins on the nurses and doctors. And they also held drop-in resiliency rounds on a regular basis. The hospital also developed something called the Peer Serious Illness Conversation Team, consisting of MGH palliative care providers that were available by phone to help any clinician with communication expertise and support before a serious illness conversation. But they were also available to support clinicians who just wanted to talk about a difficult experience or how they were coping. In addition, providers who were working back-to-back shifts or were worried about exposing their family members after work, they were allowed to sign up for hotel rooms with the cost covered by the hospital. Systems were set up to connect hospital workers in need of childcare with high school and college kids who are no longer in school and were available to babysit. And of course, cards and donated food also helped a lot. And like everyone else, we made a point of celebrating our successes with an extubation board and clapping for every patient discharged from our unit. And lastly, and I think perhaps most importantly, we really tried to get back to what we do best in pediatrics, which is family-centered care. So I think the team didn't quite know how to get to know their patients initially, as most were intubated and no visitors were allowed. I think some were also afraid to get to know their patients when they weren't really sure whether they were going to make it. But as our confidence in our care grew, and as we realized that most of our patients were doing pretty well, we leaned in. We talked by phone with family members, we FaceTimed and Zoomed, and we made all about me posters for every patient. And this did wonders for our team well-being. So I mentioned earlier the importance of careful patient selection, and we grappled with a few questions. So the first was, do we take care of COVID or non-COVID patients? And in the end, we felt it would be best for the patients and for our team to focus on just one disease process. And frankly, that's where the need really was. Age cutoffs, well, our original strategy was to try to take younger COVID ARDS patients. But frankly, these were few and far between. And those that we did have tended to be extremely sick, and many of them threatening to or in need of ECMO. Comorbidities. Well, we decided in the end that it was better to use significant comorbidities like liver failure and severe cardiac disease as a primary filter than age. We actually ended up feeling more comfortable dealing with a 65-year-old COVID ARDS patient with maybe hypertension and hyperlipidemia than we did with a younger patient with severe cardiac disease. And lastly, it was decided early on that we would accept lateral transfers from the legacy MICUs of patients following an initial stabilization to make room in the legacy MICUs to accept fresh unstable patients. Looking back, I think this was a safe way for us to get used to caring for adults and gain confidence managing them for the first couple weeks. But once we became more comfortable as a team caring for COVID adults, and once the hospital developed the centralized support teams I mentioned before, we started to take fresh admissions of unstable patients. And we actually found in the end that this was better for the patients, because we were finding that many of the early lateral transfers, they seemed to have tremendous lung de-recruitment en route from the MICUs, and this really set them back. But it was also better for the providers who could now see a single patient through all the way from start to finish. So we recently published a manuscript describing the adult patients we cared for last spring and their outcomes, and I'd like to share just a few highlights with you now. So between April and mid-May, we cared for 37 adults, 28 were COVID positive, 9 ended up testing negative. 75% of them were male, and the ages ranged quite a bit with a median of 54. 60% were Hispanic Latino, and the most common comorbidities we saw were diabetes, hyperlipidemia, obesity, and hypertension, not surprisingly. Most were intubated, pretty lengthy times, 2 to 3 weeks, with the lowest median P to F ratio of 161, and the median peak PEEP was 14. 62% underwent best PEEP trials, and half of them were prone for a median of 3 days. We extubated 15 patients, 3 of whom did require reintubation, and we ended up performing 10 tracheostomies, 3 for failed extubation and 7 for prolonged mechanical ventilation and weakness. We did have 2 mortalities. One was due to multi-organ failure, and the other following a limited trial of antibiotics and vasopressors in an elderly man with a limited code status. You can see here the disposition of all of our adult patients. Most went to the ward, but 18% were transferred to our respiratory acute care unit to be slowly liberated from the vent. And 3 needed to be transferred to one of our legacy ICUs where ECMO delivery was consolidated to optimize utilization of limited human and equipment resources. So lastly, I've included what I believe are the most important lessons learned during our pivot from pediatric to adult critical care. I'll highlight just a couple since I've touched on most of them. I would just bring your attention to number 4 and 5, which can't be underestimated. There are certain cultural differences that need to be taken into consideration when throwing together a hybrid team of adult and pediatric medical providers. And it was really helpful once we established clearly defined roles, lines of communication, and responsibilities for all members of the team. But honestly, I think that most of the items that I've listed here are pretty common management principles, but I think they do take on special importance at a time of such unprecedented strain. So with that, I think I'll stop, and thank you all so much for your attention, and turn it over to whoever it gets turned over to now.
Thanks, Phoebe. Got it. It's a great overview. I have a couple questions, and then I'll turn it over to the panelists. What, I have a total blind spot about the malpractice piece. I get the scope of, okay, the privileges piece, but as an emergency physician, it's kind of like you walk in the door. So, but is that the malpractice piece? Is that a rider that just expanded the scope of, it basically expanded the age groups, or was there more specificity in that malpractice piece? Because I obviously, well, when I said I have blind spot, that is a much bigger issue than I would have imagined. So yeah, how'd that work?
Well, so we actually invited one of our risk management lawyers to come and meet with us, and she actually happened to be a former CRICO lawyer, so she was perfect. But what she explained to us was that whatever privileges the hospital extended to our group would be automatically honored or covered by our malpractice insurance carrier. And that was, it was simple. It was as simple as
Okay, great. And then the other question, and then I'll turn over to Mike. The other question is, okay, so the list, I thought it's, yeah, I agree with, when I saw the list of what, something like 10, yeah, they are a lot of leadership principles. Well, okay, so if you had like one, if you narrowed it down to just one thing you would tell somebody that was just trying to figure out, well, they want me to do this, what's the one out of those that was maybe the most important?
Well, I think in speaking with many members of our team, I think what continually bubbles to the top is the importance and the appreciation of keeping our nurse physician PICU team together. I think that it was, it's been extremely helpful both when it comes to like just operations, but I also think that it really has contributed to a sense of well-being that we would not have been able to create by pulling together or being redeployed across the hospital. I think that's probably the one that I would select. And
Yeah, thank you. Thanks very much. Mike?
Yeah, Dr. Year, first of all, thank you for this presentation and more importantly, your leadership on this, because the country is looking for a roadmap on how to do this. And unfortunately, we're still in the middle of it, where I'm sure other children's entities are going to be faced with this. And I want to just back up in time when the decision was made by Mass General leadership to say, now our 11-bed PICU is going to become an extension of the MICU. And that means the 11 kids that are there and the kids that typically go there aren't there anymore. And just walk through in brief how the triage was, where to send them, how your normal referral patterns then had to change. I agree, you're blessed to have 3 other PICUs in the area, but that must have been and continued to be a bit of a logistic challenge.
Absolutely. Well, the first thing I would say is that the situation back in March compared to the situation we're in right now, where we are actually, again, being asked to take adults, are very different. Back in March, there had been a real lull in census across all the PICUs. So we weren't actually having to transfer out 14. It was, more like 4. And there was significant capacity at our neighboring ICUs across town. But I think that it was very difficult because it was a domino effect. All of a sudden, we realized this isn't just regionalization of ICU care, but how can we take care of these complex patients on the wards when we don't have the ability to actually provide them a higher level of care and vent support? And so I think that it was a little bit raw at first for everyone. And yet I think that we all realized that this was this was the best way that we could help out given the circumstances in our region. And I will say that the leadership across town at Boston Children's and at Tufts were wonderful and very respectful and understanding that these were our patients and that this was just temporarily they were helping out, and that with the expectation that these families would be back in our care when the dust settled. I think that there was a lot of outreach to some of our chronic kids who really had established medical home at Mass General so that these families didn't feel abandoned. And that was important work. And then in the end, we did actually keep part of one of our pediatric ward open with very carefully selected pediatric patients. And obviously our regional referral centers were all notified of this change in referral patterns, as was Boston MedFlight.
Thanks, Phoebe. Carol, and then I'm going to go to Ramon for his presentation. Carol?
Yes, you talked about the training of your staff for the medical aspect of it. It's a high morbidity and mortality rate in adults. I was wondering if you had to provide your staff more resources in terms of, number one, dealing with an increased level of death, as well as a change in death notification with an adult and management of that.
So I think, are you specifically just asking about this big change in having to get used to a patient population with so much morbidity and mortality?
Yes, and I'm sure your nurses are used to dealing with parents versus elderly people who may not even have families.
Well, I think that the development of this peer support team to be able to reach out to, either to talk in advance about having a difficult conversation with an adult, son or daughter of your patients, which is not something that we have expertise in doing, was very helpful to be able to tap into that adult palliative care experience. And then I think that there were so many resources provided, I think, to the team to help support them through having to cope with seeing so much morbidity. I mean, luckily in the end, there were only 2 deaths. Each of those deaths obviously was heartbreaking. But I think that having our pediatric palliative care providers and our pediatric psychiatrists, who even in ordinary times meet with us regularly to talk about difficult times, it was the nurses cite that as one of the things that really helped get them through those 6 weeks, was knowing that Dr. Abrams was going to come around the corner to check in on them every day and give them that space and permission to talk about how hard it was.
Phoebe, I'm going to turn this over to Ramon, but a couple comments on that. That pediatric-centric, family-centered, and also your support systems that you've built in with, as you just mentioned, psychiatry and so forth. My guess is there's quite a bit to learn from your experiences with this that's probably translatable into the adult sector with this. And I'm not sure I know all of what they are, but the huge challenges in communications that clinicians are faced with now with COVID and the, using iPads to communicate, all that. And plus, you, as you just articulate, I can't remember, the doctor that was going to come around the corner. What was his name?
Dr. Abrams.
Yeah, Dr. Abrams. See, it's a tricky thing, but you already had that beforehand, right? Okay, so we learned on the rounds that when emergency medicine tried to embed that in response to some real huge challenges in New York, that didn't work so well, but you had it embedded already. I was just thinking about how, I was thinking about your paper, and you probably got a lot more to share. That's all. So with that, I'm going to give this over to but really important stuff on that family piece, because it's just a devastating challenge with walk off from the family, and your creativity around that. I think it really.
Can I get my soapbox for 2 seconds?
Yeah, go.
I worked at a children's hospital within a hospital and a freestanding children's hospital. And I think there are challenges being a hospital in a hospital. I don't want to put words in Dr. Yeager's mouth. But I do think that ability to learn from each other, whether it's, the use of child life or even something like pet pals, that started with us, right? In the children's world. And I think the adult world, whether it's embracing palliative care, whether it's using these kind of support services, I think children's hospitals within a hospital oftentimes get to hopefully influence their MICU colleagues.
And by far the best desserts in the cafeteria. Gosh. Anyway, it's true. It's true. Anyway, let's go to Ramon. Ramon, welcome. Really appreciate your being here. Ramon Gist is the Assistant Professor of Pediatrics and Director of Pediatric Critical Care at SUNY Downstate. Ramon, really welcome you and anxious to hear from you.
Thank you so much. I will share my screen now.
Looks good.
All right.
Looks
Dr.
great,
Hunt.
Ramon.
All right, perfect. Dr. Hunt, thank you so much for that warm introduction. It is a pleasure today to speak with you all about our experience at SUNY Downstate in caring for adults in pediatrics. I have no conflicts to disclose. I would like to start by giving the audience a brief introduction about SUNY Downstate. The State University of New York has 4 academic medical centers in its system. SUNY Downstate is the Brooklyn location. We are the only academic medical center in Brooklyn. And just for context, if Brooklyn were its own city, it would be the 4th or 5th largest city in our nation. At Downstate, we have multiple colleges and schools, such as the College of Medicine, the School of Public Health. On our campus, you'll see to the bottom left, we have our 376-bed tertiary care hospital. We service a largely Afro-Caribbean population in central Brooklyn. So we can go back to March, which now seems like a lifetime ago. Back on March 1st, the pandemic started right in our backyard. On March 1st, there was one case of COVID in New York State, and by the end of the month, there were about 59,000 cases and around 1,000 deaths, excuse me. So in an effort to regionalize care, create centers of excellence, our Governor Andrew Cuomo designated our hospital as a COVID-19 only facility. Here you can see our experience with the adult COVID-19 inpatient surge prior to the designation and at the time that it was made. We were already seeing an increase in admissions and mortalities, and many units were being utilized that were not in the past. So we realized that we had to engage in some non-conventional methods in accommodating this coming surge of adult patients from our community. As you can see, we have a standard adult capacity for ICU of 26 beds between the various ICUs. We have an additional 62 vent-capable floor beds for surge capacity, and our OR, PACU, and post-interventional radiology spaces provided an additional 29 beds. But even with that, the institution had to mobilize additional units that were previously mothballed to, again, accommodate more space for patients. So our coronavirus task force, which was our EOC for the event, decided that pediatrics should be mobilized in an effort to increase our surge capacity. In our PICU, we have 12 PICU and step-down beds. We also have 11 of 20 beds on our floor, which are vent capable. So as we all know, to address surge capacity, we have to address space, which we've already addressed, systems, staff, and stuff. So we had to begin by decreasing our inpatient census. This was done by placing our PEDS ED on diversion. Once that was done, our census came down to 0, and also the adult ED was allowed to increase their surge to accommodate more adult patients coming in via EMS. One unique feature of our program is that we have a county hospital adjacent to the state hospital. At the county hospital, our residents and attendings from many of the programs at the institution have cross-coverage privileges. So we transfer our PEDS inpatient services to the county hospital, and this was important in allowing our patients to maintain continuity with their providers. We had a PICU triage protocol, which I'll get into in the next slide. We also had adult procedure teams for proning, intubation, and vascular access. For staffing, we had 2 different models. So for our floor residents, we had adult residents and fellows embedded with our pediatric residents. But for our team in the ICU, as intensivists, our PAs and our residents were the primary team, and the adult ICU consultant service made rounds with us in the morning and in the evening. For our RNs and our RTs, they also had a paired model for staffing, and everyone received just-in-time training. As a pediatric hospital within an adult hospital, we had the advantage of having easy access to adult supplies needed for care. So crash carts, nursing supplies, adult medications that were already on formulary. These were easily accessible at the beginning of the pandemic. Unfortunately, towards the end, we did have some shortages, but again, initially these were easy to obtain. So this was our protocol. It was developed because of our experience on our floor, where we had some initial difficulties and hiccups. Initially, decisions were made for triage by medical admitting residents and nurses. And in our culture at Downstate, the floor patients in the adult service tend to be sicker than floor patients in pediatrics. So there was a bit of a discordance in the comfort of our team on the floor in taking on more adult patients. So we had sicker patients on our floor initially. However, for the adults, they're more comfortable with this level of care. For phase 1 and phase 2, we had patients who were in the 30s and 40s, but however, there weren't many patients that fell in this criteria. Most patients fell into our phase 3 criteria. So here you will find our inpatient ped census trends, pre-designation, during the surge, and post-surge. So as Dr. Yeager mentioned, many ped centers were seeing a decrease in census even in early March. There weren't many kids who had acute COVID-19 disease. And then when we were designated as a COVID-19 only hospital, our census went quickly to 0, and we had a rapid increase in our adult patients on our floor and in our ICU. Now you can see here that there was a discrepancy to the amount of patients that were in our floor and our ICU. And there are 2 reasons for this. Firstly, as I mentioned to you before, the triaging at first was not the best. And as we got more comfortable with patients and our processes, the patients who came to our floor were more appropriate and started to decrease. But in the ICU, we had more of a regimented protocol for which patients would be admitted to the PICU under our service. Then as we got to late April and early May, our curve in New York City started to decrease, and the admissions also started to decrease. And so our numbers went to 0 as adult space opened up in the more traditional units. And then towards the middle of May, our census started to increase. However, we still did not have our traditional elective cases and RSV, flu, and things of that nature. We started to see more of the MIS-C phenomenon in children. So as pediatricians at SUNY Downstate, we had the unique perspective of caring for adults with COVID-19 and children with MIS-C beginning in mid-May and going into the summertime. So after everything was over and we went back to a new normal, we decided to look back in time and see how we did. So as I mentioned to you before, we used age and comorbidities as a way to triage our patients that came to the PICU. So we were able to successfully acquire a younger cohort in the PICU. We looked back at admission SOFA score, and we also were able to accept patients with a lesser degree of critical illness in our PICU. Now, admittedly, this was not part of our formal triage algorithm, but at each handoff between the adult intensivist and our team, that was part of the conversation. In terms of number of comorbidities, there ended up being no significant difference between the 2 groups in our MICU and PICU. However, if you look to the table on the right, you can see that the diagnosis in the PICU patient group were ones that a peds intensivist would on average be comfortable managing, whereas those diagnoses that were more adult specific were more triaged to our MICU. And there was a nearly significant difference in survival to discharge. And we feel that all of these efforts allowed us to feel more independent as a team, and we were able to rely less on our adult colleagues who were able to focus more on the patients who really needed their services the most. So in conclusion, once you consider regionalizing pediatrics at designated hospitals using PEDS units in general hospitals where adult staff and supplies are available to support the COVID-19 surge. We should use a system that selects for patients that has a formal assessment of critical illness along with age and comorbidities. And lastly, we should either use a model where staff are paired with pediatric providers, or we have adult providers that are available in a consultant capacity. Thank you very much.
Ramon, thanks for that presentation. And yeah, the data that you presented in terms of like your outcomes and so forth, yeah, I would feel good about that too. Congratulations, really. I'm curious, just one question, then I'll turn it over to the panelists and then I'll do the polling. I'm curious about the just-in-time training, and both of you mentioned it. What, in your experience with that just-in-time training, Ramon, what worked the best? Did you just use one modality, like you reviewed videotapes, or you had the adult ICU docs come and give a briefing or presentation, or what? And you may have used multiple modalities, but what mode worked the best in your opinion?
Sure. Actually, because of the nature of the surge, what seems to work the best is that at the bedside, just-in-time training. I mean, the volume was just so overwhelming at that time.
Yeah.
For the most part, that was the most practical way of in-servicing all of us on these modalities. And we did feel more comfortable as intensivists taking the primary role with these patients. And by being able to triage at the beginning and having lesser ill patients in our unit, it really made us feel more comfortable and allow us to function as a primary service for these patients.
Great. One quick question from each of you on the panel. Yeah, Mike.
Well, alphabetical order. Really great presentations by both of you. And this is actually a question for both of you. One of the things that was making me just not nervous, but concerned as you were speaking is, I'm sure your teams are well oiled between the emergency department and the floor, that when a kid trips getting sicker, like you're on it like Johnny on the spot. And I was so proud of how this country rose to the challenge of MISC, whether it was the academics or the children's hospitals or pediatricians. But one of the things we identified is you got to be on them fast, right? They got to get fluid resuscitation. This isn't just a kid with a fever and a rash, which 9 times out of 10 you don't worry about. These kids crash quickly. And I don't want you to, you don't have to share anything you don't want to share, but did you have any hiccups where you were concerned that some of these MISC kids didn't get as rapid a response you would have had if it was normal times? That wasn't very articulate, but I hope you know what I'm trying to get to.
I guess I'll take that question first. So actually, I felt that we were well prepared for that response. We weren't overwhelmed at the time with other admissions or sicker adult patients. So I do feel that because of how the pandemic was playing out at that time, we were able to respond, and there really weren't any delays in care that I can recall for the MISC patients. But it was more of a what works best for these patients. Is it steroids? Is it IVIG? Is this Kawasaki's? Is this not Kawasaki's? Is this strep? That was the toughest part, was teasing out what was the proper therapy for the various phenotypes of MISC.
And still a work in progress there.
Indeed.
I would just add, we took a very multidisciplinary approach to MISC in our hospital, with a very low threshold for moving kids from the ward down to the PICU with frequent repeat labs. We actually, we crashed two patients onto ECMO within as many weeks. And they were at the right, it wasn't done from the wards. It was noticed quickly that they were deteriorating, and they were brought down. And I think just that multidisciplinary approach was very important and helped us, I think, identify the declining child quickly.
Thanks. Carol, Harry, any burning questions before I go to the polls? I want to see what's going on in the world here with polls. Harry?
Just a quick one. Thank you both, because this is a real example of innovation and ways we can pivot to address this. You both had great institutional support. I'm interested if you felt like there was any place where you could have done better in terms of support or things that you needed, in particular in relation to some of the smaller facilities that may try to make similar innovations in their facilities, what they should watch out for.
So I can comment on that. I think we were, I feel extremely lucky. We were part of NETEC, and we're a regional biothreats response center. So we actually have a robust team from our PICU involved in simulations and conferences, sharing best practices around diseases of high consequence. So I think that got us off to a great start. And we did have wonderful support. I would say if there's one thing, and we do have a chance now to have sort of a do-over, it's when you throwing together this hybrid team, and not really, I certainly don't think I had a sense for what does it mean to be a medicine senior resident, and how do they function on a team in a medical ICU? And how is that going to be very different from how they're going to function when they're thrown in with a group of pediatric providers in a PICU? The cultures are so different. And I think that once that was realized, that there was great support, outreach to the Department of Medicine, and we worked collaboratively with them to actually really spell things out. And I'm hopeful that now that we're having this opportunity to do this all over again, that will be much smoother.
Yeah, and Phoebe, I hope what you're articulating carries on longer than the pandemic. Those cultural divides that we all experience in medicine among disciplines, maybe that silver lining. Yeah, that'd be nice. Mike,
I would concur. I think there are many lessons learned from our errors in triage earlier on. And I think, decisions that maybe should have been made at a more senior level when these were being made, as opposed to an MAR and a nurse who sees the bedboard, in a nursing room. I think that, being pediatrics in an adult hospital, sometimes the nuances of pediatrics are lost on our adult colleagues. And so when you have those initial hiccups, it is because of those cultural differences. And so I think going forward, we learned so much from that. And my hope is that we won't repeat that in the future.
I'll be quiet after this. I'll put a pin in something Dr. Yeager said. And I've had discussions with a lot of people about this, and it's no disrespect to any system. Mass General has a history of operating in the disaster regionalization space. University of Nebraska has it, and we are seeing examples. Everybody's doing great work. This is not diminishing it, but this country has to learn for the next one that these systems that really pay attention to these issues of regionalization, they just knock it out of the park when big things happen. Over.
yeah, and if there was one good thing that came out of Ebola,
Same thing.
and yeah, we built this. Yeah. Anyway, okay, so let's do the polls. And it's like 12:54. The polls, I think there's 8 or 9 questions. Most of them are like a yes, no kind of thing. They're really really straightforward. There's one that you have to think about a little bit. If everybody can just hang on and really focus, we'll get through these. I always look at how many people responded, and let's get through these as fast as we can. I've been vaccinated for COVID-19. Straightforward. There's no not applicables here. That's it's a yes or a no. You either got it or you didn't. I mean, All right. 4% have voted. Let's see the results. Congratulations, those of you that have gotten the vaccine already. And hopefully others are on have a number or an appointment. All right, next. Okay, this is trying to figure out who's on the rounds right now. And yes, I do forward all these results on to HHS ASPR and the Healthcare Resilience Work Group as well. Your individual responses are de-identified, and I only send over the aggregate responses. So, all right, 66% have voted. Let's stop there. That's pretty good, 2/3. It's a good mix. Wow. Great mix. All right, next. Now we get a little bit more specific. For many of these questions, I've got today, my pediatric facility or closest pediatric facility, realizing that you may have awareness of your closest peds hospital, and that information is valuable as well. So you'll see my pediatric facility or closest pediatric facility. All right, let's stop there. 61% of voted. %, care of both pediatric and adult patients. How about that? I mean, I don't know. I have no awareness about how many institutions, pediatric institutions, have like turned the switch to accommodate adults, but at least you're seeing what I'm seeing right now, the results for this. All right, next. Not yet, but planning. I saw that in the chat. Okay. Today, wait a minute, isn't this the same question? Today, my pediatric facility or closest pediatric facility is caring for pediatric patients, pediatric and adult patients don't know. Looks like the same question. Sorry about that. Hopefully we get the same result. Okay, here we go. This question is very specific to telemedicine support. Okay, so my pediatric facility or closest pediatric facility is using telemedicine to support care of COVID-19 patients. All right, let's see the results for this. 62% voted. Far more said yes than I actually thought might say yes. How about that? 30%. All right, next. This is the long one, okay? So which of the following do you believe is the most important barrier preventing pediatric ICU's care for adult patients? Lots of options, but you only get to pick one. I think I gotta, yeah. Phoebe, if I had your presentation before I made these up, I would have put the malpractice thing in there. Sorry, I just like big blind spot. All right, 50% have voted. I'll give us another 5 seconds. All right, let's stop there. 51% have voted. And it looks like by far the lack of training to support pediatric clinicians caring for adult patients. And then sort of scattered from then on. The other one is interesting. I mean, yeah, there's not a huge numbers of respondents to any of these, but the lack of real-time adult care consultation capability capacity is one that's up there too. All right, I think we have one or two more, pretty quick ones. Has your hospital canceled elective pediatric cases to make way for potential or real adult surge? And then there's one more after this one. And then we'll go around to panelists for any final comment. And then Ramon and Phoebe, you get the last word. All right, 56% have voted. Let's see the results. Hey, Mike Anderson, I'll send these on to you after we're done too. So let's see. Yes, 34%. No, 18%. All right, last one. Now, this is about COVID-19 pediatric patients. And the way I worded it purposely by your facility. So it could be adult facility, it could be, shoot, it could be like a doctor's office, whatever facility has the volume of COVID-19 pediatric patients has increased, decreased, remained the same, don't know. All right, 56% have voted. Let's see these results. It's reflecting a lot of what I'm seeing in the reports as well. Increased 32%. All right, Echo, thank you very much for helping with the polling as always. It's great. Thank you. So Harry, final comments, then Carol.
Just wanted again to say thanks to the two, and I think it's great being honest up front about things. It's great to hear about and address the differences in medical culture, and that you really address those right up front so that it didn't become a barrier, because we all know that we think differently within our specialties, and it was great to recognize that right up front and make sure it wasn't any kind of barrier. And I think that's probably a lesson for all of us that we can learn day to day and carry forward. Thank you.
Hey, thanks, Harry. And Carol?
Yeah, these are great presentations. I love the innovation, and I love how nimble you were into being able to implement this plan. It does, however, bring food for thought as we try and be prepared for the future. We all know that our pediatric ICU resources are even more limited in our nation than adult ICU resources. So as we look ahead, we need to also imagine, what if this pandemic affected children? How nimble would our adult ICUs be into transitioning to take care of pediatric patients, which I think is a bigger hurdle considering how many adult ICU folks would really pucker up if they ever had to take care of a child. But, you know, if it happens, we're going to need to be able to do that because the children are our future. Thank you.
Hey, Carol, I think about that a lot with, and kind of have flashbacks to H1N1 and the pediatric patients far more affected than adults. And it just like highlights, it's a two-way street here.
It needs to be. Okay.
And so overstated, it's almost like unprecedented. It's almost like the word unprecedented, but we're all in this together for this particularly seems pertinent. It's like, we really got to lean on each other with this. So anyway, Ramon and then Phoebe. Ramon, the mute button.
Yep. Thank you so much for this opportunity. It was great sharing my experience with you all and our experience at Downstate, and I look forward to conversing more in the future. Thank you.
Yeah, thank you.
Make, one comment and one offer. I think the comment I would make is just the importance of taking care of your team and making sure that they feel safe so that they can provide safe care. And my offer is that anybody who is facing this potential need to pivot, if there's anything that I can do to be helpful, I hope you won't hesitate to reach out. Happy to share resources with you. Thank you so much.
Thanks so much, Ramon. Thank you. I mean, you really have paved the way. As Mike said, you provided a really neat roadmap for those trying to, like, scratch their heads and work this out. So, very grateful. To our participants, thanks so much for being on. Especially like the last one of the year, people should be like inside partying. I was working on my how to say that. Yeah. And Echo, have some great time off, and be safe. We need you back. And to our panelists, Harry, Carol, thanks always for being on. And then Phoebe and Ramon, you really have reminded us of like the important, to me, it's like, yeah, the all in it together thing. And really thanks so much for stepping up. Yeah. I think you helped break down that reluctance thing in a profound way. Certainly institutions, you did it, but sharing it with others may help pave the way. So I've said it before in terms of like the announcements for upcoming rounds that we're taking the next couple of weeks off purposely with intent that we recognize the holiday, but also in support of clinicians' mental health and absolutely in support of your fighting fatigue, and really do something fun and valuable to your selves during this time. Happy holidays, and we'll see you on the next one next year. Thanks for everything. Bye.
See you next year, Rick.